Hi, and welcome. I'm Josh Lumley, and I'll be presenting the next three lectures on critical care medicine. This is going to be the first of the three-part series. There will be some information that is shared in these next three lectures that's been covered in previous lectures that you'll see from other lecturers. And obviously, as I've alluded to before, anytime you see or hear information that has been repeated by two different speakers on a variety of occasions, that's usually a sign that you need to memorize this fact, and there's a high likelihood that it will appear on the exam. So let's go ahead and get started. What are we going to talk about during this first session is the oxygen content equation, mixed venous saturation, carboxyhemoglobin, as well as methemoglobin. So for the next 5 slides, we're going to talk about the oxygen content equation. So the oxygen content equation is just one of those that you've got to remember, okay? So if you haven't memorized it yet, do it before the exam. So the arterial concentration or the arterial content of oxygen in blood equals 1.34 times hemoglobin times saturation plus 0.003 times PaO2. And what that equals out to is mLs of oxygen in 100 mLs of blood equals the mLs of oxygen in hemoglobin and the mLs of oxygen in plasma. And typically what that's going to look like is 1.34 times 15, which is the normal hemoglobin, times 1.0, so 100% saturation, plus 0.003 times 100 equals 20.7. So the typical arterial concentration or concentration of oxygen or content of oxygen is 20.7. Now, one thing I just want you to remember and take home from this equation is that hemoglobin is far more important to saturation than is PaO2. You can be anemic and can work really, really hard to drive that PaO2 up as high as possible. But bear in mind, you're multiplying that PaO2 times 0.003. Hemoglobin is multiplied times 1.34 times the saturation. So hemoglobin, adding oxygen carrying capacity to the blood in the form of hemoglobin, really is what drives the content of oxygen in the arterial blood. So now let's think about what it looks like for venous blood. So we know what the concentration is, we know what the equation is for arterial blood, CaO2. Let's talk about what it is for CvO2. So for CvO2, it's the exact same equation, 1.34 times hemoglobin times SvO2 instead of SaO2 plus 0.003 times PaO2. What we see there is on average, it's 1.34 times 15. The average venous saturation is 75%, so you multiply that times 0.75 plus 0.003, and the average PaO2 in venous blood is 47. So typically the venous content of blood is 15.2. Why is this important? Well, by subtracting the arterial content of oxygen from the venous content of oxygen, you end up getting VO2, which is the oxygen consumption. So what goes out is 20.7, what comes back is 15.2. The delta between the two of those is the oxygen consumption in the peripheral tissues, which in this case is 5.5. A low VO2 is an independent marker for increased morbidity and increased mortality. So you got these equations. These equations beget more equations. So of course we know that oxygen content leads to oxygen delivery, but it's not just the oxygen content. As I've alluded to before in other lectures, I think about oxygen delivery as a train. You've got the boxcar and the boxcar is the hemoglobin, and the boxcar is carrying oxygen. But if the boxcar is not going anywhere, it's not going to get to its end destination. So you've got to have cardiac output. So we know what oxygen content is. So for the delivery of oxygen, it's the oxygen content, so CaO2, times what the train driving forward, cardiac output. So oxygen delivery is, of course, 1.34 times hemoglobin times SaO2 plus 0.003 times PaO2, of course, which gives you the arterial content of oxygen. And then to deliver it, of course, the train going somewhere. And what is that train? What drives the train? It's cardiac output. So you multiply that times cardiac output, and that will give you the delivery of oxygen. Okay, so we've talked about the venous content of oxygen. We've talked about the arterial content of oxygen. We've talked about how hemoglobin is really, really important to driving that equation as high as possible. Arterial minus venous gives us our VO2, which is our oxygen consumption peripherally. And then last but not least, we know what the delivery of arterial oxygen is, and that is driven by cardiac output times CaO2. Now we're going to shift for the next 15 or so slides to talk about the mixed venous saturation. Question. An oximetric PA catheter is placed in a 69-year-old male patient who is undergoing surgical resection of an abdominal aortic aneurysm under GA. Before the aortic cross clamp is placed, the mixed venous saturation decreases from 75 to 60. Which of the following does not account for the decrease in mixed venous oxygen saturation? A, hypovolemia, B, bleeding, C, hypoxia, D, sepsis, or E, congestive heart failure? Give you a moment to work through that. Okay, and the answer here is D, sepsis. So hypovolemia, bleeding, hypoxia, and CHF are all going to be characterized by decreased oxygen delivery, which is going to result in a decreased mixed venous saturation. Sepsis is characterized by a high flow state and a peripheral inadequacy of the ability to withdraw or extract oxygen from the arterial blood, which elevates our SVO2. So we get an elevated mixed venous saturation in sepsis. So SVO2 equals our mixed venous saturation, and technically it needs to be assessed by a PA catheter. So on average, as we talked about earlier, the average mixed venous saturation is 75%. That's what we look for. The average, or what typical arterial concentration is, of course, 100%. So that's what we see on the left side of the heart. So on the right side of the heart, the SVO2 is pretty much assessing CVO2, which is a measure of the mixed blood. So the SVC from the upper body, the IVC from the lower body, and then the very minimal marginal input by the Thebesian veins from the heart. So if you have high SVO2, that's typically reflective of a hyperdynamic circulation. If you have an elevated cardiac output, that's typically in sepsis. So you've got an elevated cardiac output, you're tachycardic, still have a relatively normal stroke volume, you've got peripheral vasodilation, and you've got oxygen extraction in the peripheral tissues. That's abnormal. So high flow state, inadequate extraction of oxygen, so oxygen unloading is skipped over, and what comes back and what is seen back at the heart is actually a higher than normal SVO2. Now, if you have a low mixed venous, that's stagnant circulation. So that is a lower circulatory state. So let's say we drop from an SVO2 of 75 to 60, like in our question state, or as we see in this case here, we've got an SVO2 that's actually dropped to 50%. So what I want you to think about is, let's just say cardiac output stops. Boom, stops. No cardiac output at all. The train is no longer driving forward. Well, offloading of oxygen from hemoglobin does not stop with decreased cardiac output. So VO2, extraction and consumption of oxygen, that's going to remain the same. So when cardiac output picks up again, you're going to have more train cars that are unloaded with oxygen, and what's coming back for pickup of oxygen to the heart is going to be hemoglobin that's going to be more desaturated. So oxygen content is going to be reduced and our SVO2 is lower. So what are some of the other causes of low mixed venous saturation? So even if cardiac output remains the same, in a hypoxic state, what you're starting with, what's leaving the heart, is actually lower arterial content of oxygen. So let's just say our saturation is lower. It goes from 100% to 90%. So as that 100% drops to 90%, our PaO2 in that case is going to be 60, so 60 times 0.003, that's nothing. There's no impact, there's no contribution whatsoever on the second part of the arterial content of oxygen equation. So really all we're focused on is the first part, which is the 1.34 times hemoglobin times saturation. So 1.34 times 15 times 0.9 is actually 18. Okay, so we have now gone down in number from 20. Our peripheral extraction of oxygen, our VO2 remains the same, which, as you remember from the previous section, normal VO2 is 5.5. So we can backtrack into the CVO2 equation to CVO2 equals 18 minus 5.5 minus the VO2, which gives us 12.5. 12.5 equals 1.34 times hemoglobin times SVO2. Doing the math, you get an SVO2 of 0.62, which is lower than 75. So cardiac outputs remain the same. VO2 has remained the same, but the train cars that are getting to the peripheral tissue are not filled as much with oxygen. So we got the same amount of boxcars, they're just not filled up with oxygen as well as they should be. So we are in a hypoxic state. Now, this is a challenging question. I'm going to give you some time to work through it initially, and then we're going to work through what each condition is and how we get to the final answer. So you've got this chart of condition 1, condition 2, condition 3, condition 4, condition 5. This matches up to severe GI hemorrhage, acute myocardial infarction, septic shock, right ventricular infarction, cardiac tamponade. Select which one of those numbers matches up to A, B, C, D, or E. Give you a second to take a look at that. And in fact, you may want to push pause on this right now and kind of work through this, because this question is going to take a lot of time for you to work through. Okay, so we're going to go forward. Now, what are things that we can totally rule out? So to kind of drill down and get to a final answer more quickly, let's look at the SBP column and the heart rate column. SBP is low all the way across the board. Heart rate is high across the board. So in your mind, let's just black those two out, because those are not going to tell us anything. So now all we're focused on is right atrial pressure, PA pressures, PA occlusion pressures, and cardiac index. So right atrial pressures, cardiac index, and occlusion pressures. So right atrial pressures and PA pressures are going to kind of be an assessment of what the right side of the heart looks like. PA occlusion pressures and cardiac index is going to be an assessment of how the left side of the heart looks. Okay? So first things first is, if we look at the third line, we see that right atrial pressure equals the diastolic PA pressures and PA occlusion pressures. So you have an equilibration of pressures across all four chambers in this. Does that match up to anything? Yes, it does. That is cardiac tamponade. So cardiac tamponade is the equilibration of pressures across all four chambers of the heart. We will talk about cardiac tamponade during our cardiovascular lectures. So now we're faced with GI hemorrhage, MI, septic shock, and RV infarction. So let's look at the two that have low right atrial pressures. So we know what the answer is for line 3. So now let's look at, we're left with 4 choices for the last 4 answers. And so we've got 2 answers that have low right atrial pressures, low-ish PA pressures, low PA occlusion pressures, and one that has a high cardiac index and one that has a low cardiac index. So looking at that, which of those remaining answers has a high cardiac index? Well, we know that in a hyperdynamic state, septic shock has a high cardiac index. So that means that septic shock matches up with line 1. And now we're faced with what other one has a low right atrial pressure? Well, an MI is not going to have low right atrial pressure, nor is it going to have and certainly not a right ventricular infarction. They're both going to have elevated right atrial pressures due to dysfunction of the left side of the heart, or the right side of the heart in that case. So in this one, we know that the 4th column matches up with severe GI hemorrhage. Okay, so severe GI hemorrhage and septic shock matches up with line 1 and line 4 respectively. So now we are left with answers B and D, and choosing between those 2 answers. So now we're left with 2 answers, one of which that has a elevated right atrial pressure. So both of them have elevated right atrial pressures. One of them has a normal PA pressure. One of them has a normal pulmonary PA occlusion pressure, and the other one has a elevated right atrial pressure, has an elevated PA pressure, and has an elevated PA occlusion pressure. Well, the answer there is, of course, going to be the answer that has the elevated PA. Sorry, I fast forwarded too much. So the one that has elevated right atrial pressures and dysfunction of the left side of the heart, so elevated PA occlusion pressures, is going to match up with B, acute myocardial infarction. And the right ventricular infarction is not going to affect the left side of the heart, so PA occlusion pressures will be normal. And our right atrial pressures and PA pressures, so right atrial pressures, will be elevated. PA pressures not dramatically elevated. So in that case there, the fifth line matches up with right ventricular infarction. So let's go back through this one more time. The answers are septic shock here, MI here, tamponade here, GI hemorrhage here, and right ventricular infarction here. Answers, of course, what the giveaway for this one. So septic shock is the one that we sort of ruled out initially as comparing it to GI hemorrhage, which is this answer here. So low right atrial pressures, normal to lowish PA pressures, low PA occlusion pressures, but one with a high cardiac index, one with a low cardiac index. High cardiac index is septic shock, low cardiac index is GI hemorrhage. Now, in this middle one, we saw equilibration, right atrial pressure, PA pressure 18, PA occlusion pressure 18, equilibration across the 4 chambers of the heart. That is a hallmark for cardiac tamponade. And now we're left with what's the difference between acute MI and right ventricular infarction. So for acute MI, we see elevated right atrial pressures, we said elevated PA pressures, and elevated PA occlusion pressures in the face of a low cardiac index. That matches up with acute myocardial infarction. And then for right ventricular infarction, we only see elevated right atrial pressures, which of course makes sense. There's no effect really on PA pressures or PA occlusion pressures, only affects the right side of the heart. Therefore, the answer there is D. Now again, this was a complex question. My advice would be to go through this multiple times, replay this section, Be able to tell yourself exactly why each answer matches up with each choice. Okay, now we're going to hop into carboxyhemoglobin and methemoglobin. A 33-year-old woman with 20% carboxyhemoglobin is brought to the emergency department for treatment of smoke inhalation. Which of the following is least consistent with a diagnosis of carbon monoxide poisoning? Okay, and the answer here is A, cyanosis. So carboxyhemoglobin is characterized by cherry red skin, so cyanosis is incorrect. I should go through these answers here. What we see is carbon monoxide poisoning actually artificially elevates the PaO2. So we see a PaO2 that's relatively normal on room air. And saturation with co-oximetry is actually going to be, oxygen saturation is actually going to be high with carboxyhemoglobin. You're going to see normal oxygen saturation on dual wavelength oximetry, and then you're going to see a left, you are going to see a left shift of the oxyhemoglobin dissociation curve, and patients are going to describe dizziness due to their carboxyhemoglobin levels being elevated. A 32-year-old male is found unconscious by the fire department in a room where he has inhaled 0.1% carbon monoxide for a prolonged period. His respiratory rate is 42 breaths per minute, but he is not cyanotic. Carbon monoxide has increased this patient's minute ventilation by which of the following mechanisms? A, shifting the O2 hemoglobin dissociation curve to the left. B, increasing carbon dioxide production. C, causing lactic acidosis. D, decreasing PaO2, or E, producing methemoglobin. And the answer here is C, causing lactic acidosis. So just shifting the oxyhemoglobin dissociation curve, while that does happen with carbon monoxide poisoning, that does not increase respiratory rate. Increasing carbon dioxide production, that's not happening in this situation here. Carbon monoxide poisoning, it actually results in an elevated PaO2, as I alluded to earlier. There is no methemoglobin production. It's not germane to this. In this case here, we do have lactic acidosis that's being produced because we have tissue that is not receiving the adequate oxygen concentration. So it goes into anaerobic metabolism, developing lactic acidosis. When you have elevations in lactic acidosis, you have increases in hydrogen ions in the CSF. Those increasing hydrogen ions in the CSF are detected in the medulla, which triggers an increase in respiratory rate. Okay, so what about the difference between carbon monoxide poisoning or carboxyhemoglobinemia and methemoglobinemia? So these are two hemoglobinopathies which will certainly make their presence known on your exam. So let's go on the left side with carboxyhemoglobin first. So pathophysiology is carbon monoxide has an affinity 200 times that of oxygen. So there may be oxygen in the blood, but the carboxyhemoglobin is, carbon monoxide is avidly bound to hemoglobin, and there's just no room for oxygen to adhere or join the molecule. And so we get a left shift of the oxyhemoglobin dissociation curve, and if you have over 50%, it's universally fatal. So will our saturation on ABG look normal? Yes, it will. Will our pulse oximetry look normal? With co-oximetry on carboxyhemoglobin, yes, it will look normal. Signs and symptoms, the patient is going to be cherry red. Why? Because that hemoglobin has avidly bound carbon monoxide, and so the patient is going to be bright red. And so diagnosis for this is going to be using 4-wavelength or co-oximetry for diagnosis of instead of dual wavelength pulse oximetry to diagnose the presence of carbon monoxide and be able to tell that they have carbon monoxide poisoning. Therapy is hyperbaric oxygen or 100% oxygen first-line therapy. If there are secondary effects like the mom is pregnant or there are signs and symptoms of cardiac ischemia, then you need to go to hyperbaric oxygen. Half-life is 1 hour for carbon monoxide with the use of 100% oxygen. If you put them on just room air, it's 6-hour half-life. Okay, so now let's go to methemoglobin. So with methemoglobin, commonly caused by benzocaine and prilocaine. Those are the two that you definitely need to remember. Absolutely. So you oftentimes talk about a person who does hurricane spray is kind of the question stem, the way this presents. 10 to 25% of methemoglobin presents as cyanosis. If you have over 70% of it, that is lethal. Our ABG, our saturation there, does it appear normal? Yes, it does. Pulse oximetry here actually presents as 87%. When you draw a ABG on this patient, the blood appears chocolate brown. They kind of describe it as being thick, viscous, and chocolate brown. The therapy for methemoglobinemia is methylene blue. You definitely need to memorize this chart. So the other thing is that carbon monoxide poisoning, it does not cause hypoxia. We do not see a low PaO2. So with hypoxia, the strict definition of hypoxia is a low PaO2, and there are 6 causes: low FiO2, hypoventilation, VQ mismatch, shunt, decreased DLCO, and shock. Hypoxemia, on the other hand, is a low concentration of oxygen or a low content of oxygen in arterial blood. Here, of course, we know the calculation is 1.34 times hemoglobin times the saturation plus 0.003 times PaO2. And that is it for our first of 3 lectures on critical care medicine. Thank you.